Surgical site infection is a common healthcare associated infection and complicates 10 to 15% of operations, with considerable healthcare resources expended in the process of treating it. Despite antibiotic prophylaxis, innovations and care bundles, the incidence of surgical site infection is not falling, but is proportionally rising as the most common healthcare associated infection. This video aims to highlight practices in operating theatres and on the wards, as well as post-discharge care, where patients could be put at risk of surgical site infection. The mandatory aseptic non-touch training and basic surgical scrubbing training are not sufficient to reduce risk. Here, a healthcare worker touches the inside of the sterile gown packaging, which is incorrect. Here, a healthcare worker handles the sterile packaging before placing gloves on the sterile gown, which also is incorrect. Now, a healthcare worker is carefully opening the gown packaging without touching the inside of the packaging and therefore avoiding contamination. Here, a healthcare worker opens the gloves without touching the packaging of either the gloves or gown. This video is not intended to teach surgical hand washing. Appropriate hands-on training is recommended. The hand towel is used inappropriately. The towel touches the hands, the forearm and the elbow, but returns to the hands, potentially contaminating them. The hand towel is used to dry the hand, the wrist, the forearm and finally the elbow. It is then disposed of without going back to the hands. Inappropriate handling of a gown. The gown was in contact with the surrounding environment, including the work surface and the wall. After initially donning the gown, the healthcare worker touches the upper part, contaminating it. Correct procedure. Handle the gown at the collar, let it drop and open without it touching any non-sterile surfaces or objects. Poor gloving practice. The healthcare worker's hands touch the outer sterile side of the gloves, which will be in direct contact with the surgical field. Good gloving practice. Using appropriate closed donning technique, the healthcare worker's hands are in contact only with the inner side of the gloves. For detailed open and closed donning techniques, refer to appropriate training resources. Poor gloving practice. The hands are clean after washing, but are not sterile. The outer side of the gloves will be in contact with the sterile operating field, but the healthcare worker's hands touch the outer side whilst she is putting them on. Her hands should touch only the inner side of the gloves. Good gloving practice. The gloves are put on without touching the outer or patient side of the gloves. Poor instrument tray handling. One of the circulating staff touches the tray. This can cause contamination of instruments, then the scrub nurses' and surgeons' hands, and eventually the surgical site. Poor skin preparation technique. After cleansing the other parts, the healthcare worker proceeds to clean the anus and then returns to other areas, thus risking contamination of parts already cleansed. Good skin preparation technique. The correct order for surgical skin preparation is external genitalia, groins, thighs, perineum, and finally the anus, after which the swab must be discarded. Poor vaginal preparation technique. The vagina is cleansed, but the anterior commissure and periurethral area are missed. The surgical site is not fully cleansed. It is important to clean the whole of the external genitalia, including the periurethral area, whether catheterization is intended or not. The periurethral area and urethral meatus have not been cleansed, but a catheter is inserted. This risks introducing pathogens into the lower urinary tract. Good vaginal cleansing. Having cleansed the external genitalia and perineum, we now see a systematic approach to vaginal cleansing, starting at the periurethral area, proceeding to the lower vagina, and ending with the upper vagina, giving particular attention to the fornices around the cervix. Poor umbilical cleansing. When cleaning before laparoscopy, if the incision is intended to be intra-umbilical, superficial cleansing of the umbilicus is not sufficient, especially for patients with a deep umbilicus where skin debris collects. Good umbilical cleansing. The healthcare worker uses forceps to hold a swab soaked in skin prep solution and cleans the umbilicus thoroughly using a circular motion. This should be repeated until all umbilical debris has been removed. Poor draping technique. The surgeon's gloves and sleeves touch the patient's buttocks and thighs where skin prep has not been applied. Good draping technique. The surgeon carefully places the drape under the buttocks, ensuring that her gloves and sleeves do not come into contact with skin where skin prep has not been applied. This can be achieved by covering the gloves and sleeves with part of the sterile drape before placing it under the buttocks. Poor draping technique. The drape touches the floor and the seat, resulting in contamination. The surgeon then handles the leg support covered with contaminated drapes. The surgeon's gloves are now contaminated. Good draping technique. The surgeon handles the drape with care, not allowing any part to touch the floor. Poor draping technique. After having placed the sterile drape, the surgeon touches the non-sterile blanket. Poor practice. Whilst giving intravenous medication, the anaesthetist and operating department practitioner contaminate the sterile operative field. Good practice. The use of a screen improves access to the patient's arms and chest, whilst better delineating the sterile operative field from unsterile areas. The anaesthetist and operating department practitioner give intravenous medication whilst avoiding the sterile area. Poor specimen handling. Whilst putting a specimen in the specimen pot, the surgeon dips an instrument in formalin. She then puts the instrument contaminated with formalin back into the patient's body. Formalin is for preservation of tissue specimens. The patient does not yet need preservation. Good specimen handling. The surgeon puts a specimen in the specimen pot. She then removes the formalin contaminated instrument from the sterile instrument tray. Alternatively, the specimen can be placed in a container, such as a gallipot or kidney dish, and be handed to circulating staff, so that the surgeon's instruments are not contaminated with formalin. For short procedures, the specimen can be placed in the specimen pot at the end of the procedure, when instruments are no longer needed. A commonly observed practice on wards is patients walking barefoot or wearing only socks or anti-embolic stockings. Patients should be advised to wear slippers or footwear with a waterproof sole to avoid cross-infection. Patients may be poorly advised by healthcare workers, family or others to soak in the bath to soften the stitches. This is sometimes done as early as the immediate post-operative period. This practice risks wound infection, especially if patients use the bath after walking barefoot around the ward or after using the toilets. Maintain hygiene by showering, but for most of the time the wound should be kept dry.